Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, I have the pleasure of being joined by Dr. Maryam Motlagh. Dr. Motlagh has devoted her career to advancing patient health by addressing the critical connections between oral health, occlusion, TMD disorders, upper airway health, and overall body function. She obtained her DMD from Oregon Health Sciences University School of Dentistry and maintains a private practice in Portland, Oregon. She has pursued extensive postdoctoral training in occlusion, sleep dentistry, and complex restorative dentistry from prestigious institutions such as the Academy of Cosmetic Dentistry, the Spear Institute, Las Vegas Institute for Advanced Dental Studies, and the International College of Craniomandibular Orthopedics, where she has earned mastership status. Dr. Motlagh is also the developer of MyAligner, an FDA-cleared device for the treatment of TMD disorders and migraines. It is her mission to make TMD and functional orthodontic treatments more accessible by empowering dentists with cutting-edge knowledge and innovations. Some of what we will be discussing during today's show includes how Maryam became involved in physiologic dentistry, the real reasons why occlusions break down and restorations fail, why it is important to view occlusion as a neurologic and respiratory issue, not just a mechanical one, what most dentists, including orthodontists, are missing in their diagnostic workups when it comes to the temporomandibular joint, how finding neuromuscular balance can greatly improve orthodontic and restorative treatment results and stability, the need to focus on individualized, patient-centered care and not device-driven treatment, why Maryam created MyAligner and how it can help as a diagnostic tool and as a bridge from orthopedics to orthodontics to restorative care, and much, much more. So without further ado, let's get on to today's episode with Dr. Maryam Motlagh. Enjoy the show, everybody. Welcome to Doc Podcast, Maryam.
Thank you. It's a pleasure to be here.
I'm very happy to have you. I'm looking forward to today's conversation. We're going to talk about some pretty cool things. And it's interesting because in the orthodontic world, we have certain disciplines. We tend to have certain dogmas that we follow based on how we were trained. One of those disciplines is the Roth philosophy, which many people know of. Some schools still teach it and still embrace that philosophy. And that's the concept that you basically articulate every case and try to find what we would call the CR, or centric relation, and then treat to that point. So this exists within orthodontics, a lot of what we're going to talk about today. But you have taken, in your restorative and general dental background, have taken a whole different type of approach to that. And it's really fascinating. And I think what happens in orthodontics is we don't spend enough time in understanding all the compensations and the neuromuscular and occlusal compensations that happen over time to our patients, even in kids, but especially in our adult restorative cases. And I think that causes us a lot of frustration. I can speak to it myself, having practiced for many, many years and had some complicated restorative interdisciplinary cases where you feel like you're just not able to get that occlusion to settle in. And you have some really cool, innovative solutions for that, as well as some amazing experience in that arena. So we will dive into that in some detail today. We'll also, if we have time, we will switch over and show a little case sample toward the end. So at that time, for anyone listening in audio, I will certainly let you know that it is a chance to hop over to the YouTube channel to watch it in video. So we'll see if we have time for that at the end as well. But before we get going into some of the content we're going to discuss, if you would, please tell the audience a little bit more about who you are and your background and how you got to this point in your life and career.
Thank you. Maryam Motlagh. I went to OHSU here. I've been an Oregon resident for almost 40 years. So I continued my education here, undergraduate from OHSU. But I feel like when I graduated, I knew very little about TMD and occlusion. So I pursued my studies with Spear seminars, and learn a lot about CR and occlusion, complex aesthetics. You all remember like extreme makeovers. I was very fascinated with extreme makeovers, and I was doing a lot of complex veneer and full mouth reconstruction cases. After a few years, I noticed that not only my own cases did not have much stability. A veneer case, 28 veneer case that I did on completely worn down teeth, they started to chip and break, and it was usually not a material problem, and it was more of a functional stability, similar to what orthodontists run into. We even today I see some beautiful orthodontic work that is done. You have a lingual wire holding everything, but then posteriors are completely lingually inclined, and the posterior is collapsing. So I started to dig into more and more function to see what these patients were doing with their masticatory muscles to destroy my work, basically. And it was soon after that I learned muscles dominate, and an airway basically dominates. These patients were trying to open up their airway. Most of the wear and tear that you see, it's more of a protrusive pattern. But have your patients bite down, and you can see the wear pattern on their anterior teeth. So why are they functioning? Why do we see such a wear pattern in that protrusive position? And then I got into more airway and sleep apnea and side of the dentistry, and I see that this is all related. And really, for us to have stability, us dentists, we're perfectionists. We want to place that crown margin, like there's perfectly sealed. We take x-rays to make sure our margins are okay. But then oftentimes I saw that teeth broke at the gum line. My perfect crown was still in a perfect position, but the tooth underneath was gone. And oftentimes I saw several endodontically treated teeth that were still symptomatic. So there's no nerves in these teeth. What is causing the pain? Could it be from ligament? Could it be from occlusal trauma on these teeth? And I see that every day in my practice. So that's why I expanded my knowledge into more looking at the function. What are these patients doing and why they're doing this? And that's when I realized, okay, 86% of population suffers from malocclusion in modern societies, and about 30% of, according to mega studies, about 30% of these people are symptomatic with TMD, jaw joint popping and clicking. So it really, changed my approach to more of a comprehensive approach to dentistry, looking beyond just the mechanics of teeth. So that's kind of like my background, and that's 25 years now, and I've been practicing more of a physiologic approach to dentistry, taking all those into consideration, taking function and airway into consideration. And after that, I'm seeing a lot of stability, full mouth reconstructions that stay stable for 15, 20 years. And I constantly take pictures of them and document them. So it's been amazing to see stability. We don't want to fail. We don't want our works to fail.
Yeah, and that's something that, thank you for sharing that. And what you hit on that's interesting is occlusal breakdown, right? Why are these patients breaking down occlusally? And that is why I feel that restorative dentists, especially, are more in tune to the pathologic conditions that cause malocclusion and relapse of previously treated orthodontic cases or previously treated restorative cases, as you alluded to, because you have to live with it.
Yes.
We kind of don't, right? Like, we can blame the patient they didn't wear the retainers, and it might be true. I mean, there were many cases they didn't wear them, but we don't take a lot of responsibility for the long-term success of our cases in ortho. We have that luxury. A restorative dentist, and I come from a family of them and have many friends who are in restorative dentistry, they don't have that luxury, especially if you're in the same community practicing for decades. Doc, why did I put $75,000 into my mouth and 7 years later it's falling apart again, right? And so I give you credit for recognizing that and saying, I'm not just going to keep trying to use stronger materials or give them more dentistry, meaning maybe now crown the opposing arch as well, right? Trying to get the tooth structure out of it, the tooth structure is breaking down. And I really wish people just thought of it more in that holistic manner and approach. And that's what leads you oftentimes to airway. I think so many times people think people think everything's airway, and they just want to prove everything is airway. I want you to elaborate a little bit more on what you said, that so many of the times you see the breakdown, there is a relationship to airway? And this could be occlusal breakdown, TMJ breakdown. Talk a little bit more about that, if you would.
Yeah. Well, we know form follows function, and function follows airway. Air always wins. So our patients, if they have forward head posture, they're trying to open up their airway. And all the patients that are in like mandibular advancement devices at nighttime devices, what are they doing? They're just bringing the mandibles forward. And for many years, we haven't been looking at the airway and at function. So that's the masticatory muscles are part of the airway, and if it's not open, if it's collapsed, our patients will do anything, even busting their front teeth, to open up their airway. Tongue posture, as you mentioned retainers. I think we all have the best retainer in our mouth, which is our tongue. With every swallow, 5,000 times a day we swallow. What happens? We need to press the tongue against the roof of the mouth, and teeth gently touch. So if you have somebody that has a retracted jaw, skeletal class 2, retracted mandible, every time they swallow, they're just trapping that tongue in their mouth because they have a collapsed video, they have a retracted mandible. So these patients have to have forward head posture to open up their airway. And this is not, complex science. Just do that for yourself. As I'm talking, if I push my mandible back, you can see my airway closes. I can hold that mandible back and then tip my head forward, and then I have an open airway. So posture becomes a factor in this. I often have my students in the class just stand up and you can try this if you're listening to this, take a break, stand up, and just gently bring your teeth together. Now give yourself a crooked posture by just dropping one knee, tilting your hip, and now gently bring your teeth together, and you can see that your teeth are hitting differently on the posteriors. Or even tilting the head back or side to side. Why? Because we just changed the alignment of the cranial base. What is hanging from that cranial base? It's mandible. And the mandible has no bony connection to the maxilla except with muscles. So as you tilt your head or hip and the head tilts, the axis of closure of the mandible changes. I've had patients that had full mouth reconstruction. 5 years later, they come back and they said, this patient told me I have no occlusion on one side. Obviously, any dentist would just grab an articulating tape, tap, tap, tap. Okay, let me grind the other side.
Right.
The level of occlusion. What I did, I just explored. Again, patient history is so important.
Yes, thank you.
I started asking her what has been going on. And she's not my patient because she was referred to me for full mouth reconstruction. So I realized that she just had a ski accident. So before I touched my handpiece, I sent her to a chiropractor, adjusted her neck, and the occlusion came back to normal.
Wow.
These are things that, as you mentioned, general dentists, I had the luxury of practicing as a general dentist and service to patients for the past 25 years in the same practice. So I can see these long-term results. Yeah. And the majority of our dentists, they're in the same position. And every case that we start can be part of a big research project because, we are documenting these cases. All my chart notes, all my CT scans are part of this big collective research approach that we can, after thousands of different specialties document these cases, then we can see this is evidence-based dentistry that we.
Yeah, it completely is evidence-based. And I say it often as well. And when I lecture and talk to residents about this all the time, evidence basis, as Sackett designed it, is not about having a randomized control trial for every single situation. That is not what it is. Yes, one piece of the triangular epistemology that Sackett developed is the research, right? The science behind it, so to speak. The other two pieces, which are equal in weight, are the patient values and preferences, right, which we have to take into account. And so many practitioners are, I will say, not great at that, right? I'm the doctor. When this is not just pointing fingers at any particular dentist, this is just in medicine and dentistry in general. A lot of providers, it's like, I'm the doctor, I know best, this is what you're going to do. And so that's not evidence-based. And the other is the clinical experience, as you just alluded to. That's an equal part. And only in the confluence of those three circles of a Venn diagram, so to speak, where they overlap, is where evidence-based practice exists. And so what you're doing and saying is you're taking the science, the data, the literature. We know that there are certain abnormalities. We know sleep causes and is related to bruxism. That is all over the medical literature, right? So you have a patient come in bruxing. What do we do about that? Well, we need to talk to the patient and see where their pain points are and what they want. And then we need to use our clinical experience to say, geez, let me think about this. If this patient has 7 millimeters of overjet, how, when they go into protrusive and edge to edge, does it fit like two pieces of a puzzle that were expertly crafted to fit together in a way that you could never do synthetically, right? Only nature could wear two opposing objects with this level of perfection. So many times, Maryam, through my career, I saw that. And I'm embarrassed to say, I never stopped and thought about the fact that they're not hitting those teeth in function. I mean, we know that, right? Like they're not chewing on their front teeth. They might use their front teeth to incise, but they're not chewing. And even if they do, it's not like it would be like with a horse or a cow where it's a lateral side to side chewing. They're still going through that normal envelope of masticatory motion. And sometimes it'll happen in like an 11-year-old kid or younger. And I'm like, they've only had these teeth for a few years, and now they've worn 1 to 2 millimeter wear facets into their incisors. And we're not curious about that. Like, we're just like, oh, it's because they have a deep bite. Well, maybe, like you said, they're trying to put their mandible in a position where we put them when we use mandibular advancement devices, as you alluded to. So why do you think we don't think about this stuff more? You know, you said the first thing you do is you want the patient history. What is your opinion on why we, and I'll say we as orthodontists, because we're definitely guilty of this in the ortho world, jump so quickly into the treatment side? And I think general dentists can be doing that too. Pediatric dentists, right? They're quick to restore broken down teeth. And like, why as a profession of dentistry are we so quick to jump to the fix and we don't spend enough time in the diagnostics?
I think because we were trained as tooth mechanics and not the doctors of the oral cavity.
Fair.
You know, we learned to look inside the mouth, not sit back and look at the face, look at the body, look at the connection of the orthopedic alignment of the head and neck to the rest, and function. There was no mention of function at dental school. I presented to dental students a couple of weeks ago at OHSU. And still today, they're not getting any training of the connection between airway and TMD and function. Wow. So that's very unfortunate. You know, they have a 2-hour class on pathology of the TMJ joints, but why did the head condyle bend like that? Why is the head condyle wearing down so much? It's not a disease of the joints. It's a function, because form follows function. It's a functional issue, and we didn't emphasize much on that at dental school. So I think maybe post dental school studies would help. You know, dentists will taking some classes after dental school on understanding the physiology of occlusion would help a lot. And ignoring it will just end up with failures. If you like to see failures in your practice, you know, that, it's not fulfilling, definitely not fulfilling. When you offer more of a comprehensive approach, it's very fulfilling. The other thing could be that it can get complicated. People like simple things, you know, so
I agree.
When there's such a multifaceted issue, you know, and that's why it's hard to do randomized clinical trials. Unlike antibiotics, you know, right. If somebody is suffering from airway issue, TMD, maybe a little bit of a psychological, you know, grinding and clenching, because it all influences it. Malocclusion. How do you do clinical trials on a big group of people? Do you use sham appliances on them? It brings up ethical issues
completely.
Too.
Yeah. Especially if you know that what you're doing in some regard is helping them by not providing that care. They call it the equipoise, as they say with IRB, the review boards and the institutions. They require a certain amount of ethical criteria to be met in order to satisfy conducting a randomized controlled trial. So all the time we'll hear from our colleagues, well, there's no randomized controlled trial. They leave out the part. I actually recently published an article on this in OrthoTown to highlight that. I can post a link to it in the show notes to highlight the fact that it's evident, especially orthodontics is one of the least evidence-based professions out there. It's just a fact. Like, I'm an orthodontist. I can say it. I'm one of them, right? I'm not pointing fingers. Like, it is highly, highly based off of convention, off of history, off of clinical trials. I'm not even knocking it. I'm not saying you need a randomized controlled trial to decide one bracket prescription over the other, right? Or whether in this patient you should use clear aligners or brackets. But we need to be consistent here in what we're calling for, right? If we're going to be using all these different things in our practices that aren't backed by randomized controlled trials, and then we look at something else and say, well, I won't touch that because it doesn't have a randomized controlled trial. Let's just step away from hypocrisy for a moment and acknowledge that it's an imperfect science. And we have to then, according to Sackett and his triangular epistemology, rely on our clinical background and skill, right? And clinical data, which is what we do all the time, and the patient preferences. On that note, I feel like we don't think enough in ortho about the TMJ apparatus. I feel like unless a patient comes in symptomatic, saying, "Doc, I can't chew. I have constant headaches up in the temporal area. I have a terrible click. My jaw locks," right? All those are all things when patients come in, we know there's clearly an issue, and we're trained to start to look more into those issues and figure out what's going on. I feel absent that, we're kind of like, oh, they have a little click, fine. They have this. We don't know how to really sense, and because unfortunately not as many people are taking CBCTs as I feel should, they don't see it. It's virtually impossible to really see it well on a pan. So they're not really analyzing the joint and the joint anatomy. And so I feel like we miss a lot of things, and I'm guilty of this too, especially before I had CBCT. You start a case, you're not, maybe a patient, a little click at new patient exam, and I always check that, always going all the way back. But all of a sudden, I'm 6 months, 9 months into treatment, and the patient's coming in saying, my jaw's locking, my jaw's clicking. Yeah, you look at the ortho literature and everything that you can see after that lawsuit in 1986, I believe it was one of the biggest settlements, right, in all of orthodontic litigation. All of a sudden, all sorts of literature came out in the orthodontic literature talking about how orthodontics has no impact on the temporomandibular joint, right? No impact, like not positive, not negative, which is a lie, because we know that orthodontically we can help patients to have, I helped so many patients have complete resolution of their TMD by adjusting the occlusion, neuromuscular adaptation, working with, I didn't do a lot of the deprogramming. We're going to talk more about that. And I love your approach to that. But I had some docs I worked with in my area who were great at the deprogramming, at the TMD side. And then they would send the patient to me. Once the patient was stabilized and comfortable, I would go in and perform the orthodontics. And we got some beautiful, beautiful results with those cases. So why is it okay to say I can help the TMJ, but I can't hurt it? Come on. I think we all know that it's a bit of a protective thing. I think early treatment and airway fall under that same category orthodontically. But why do you feel as orthodontists we aren't more in tune to looking at the temporomandibular joint apparatus proactively?
Because I think that's part of the orthopedics of the head and neck. And I think there's been a disconnect between orthodontics and orthopedics. Fair. Of the head and neck. Yeah. You mentioned last time that when we were talking that usually orthodontists, when they see a TMD issue, most of them will send the patient out of their practice to somebody that has more TMD practice. And then they bring the patient back in and they start treating him. Exactly. Why? That the orthodontists should be the experts. They're the ones that have more training than a general dentist on cephalometric, analysis, skeletal analysis, occlusal analysis. They're the ones that are equipped with this knowledge in dental school. They just need to look at it and look at the airway. So on those lateral septs, you can see the airway. You can see the skeletal malformation. You can see underdeveloped maxillas and mandibles. So these are the things that should be, in my opinion, should be handled by our specialists who are the orthodontists.
I think, sorry to interrupt you on that, but I think a lot of it is, it doesn't fit within our practice model. Truthfully, just to be completely honest, like dealing with a TMD patient and when they are It's a chronic problem that those patients need a lot of adjustment visits. They need a lot of time and attention. There's a lot of, as you said, diagnostic work. There's a lot of work that it doesn't fit in our practice model. And I think it's the same thing with a lot of airway focused treatment. It just doesn't. Our practice models are built to straighten teeth and straighten a lot of them quickly. That we are trying to have as few visits as possible. I mean, look at any consultant. What are the best consultants trying to get their docs to do? Right? Shorten treatment time, maximize efficiency, and maximize production with the least amount of clinical time spent. Mm-hmm. When that's your mentality, of course you're going to reject airway related care that requires a whole nother level of diagnostics and treatment philosophies and approaches and interdisciplinary care. Of course you're not going to want to incorporate TMD management into it with a lot of those cases. It doesn't fit.
Well, actually, I think that creates not paying attention to that creates more complexity.
That's why I agree. Right. I know.
But 120 aligners.
Yeah, it's so true. Yeah, we'll talk about that a little more, but that's a great point.
Yeah. Let's say you have a narrow maxilla, underdeveloped maxilla on one side. So you have asymmetry, and we have a case that we can show you some examples of that. Mm-hmm. What is occlusion? Where when we ask the patients to bite down, they want to get maximum intercuspation. So that mandible that's hanging from the maxilla will just adapt to that. Let's say you have a unilateral crossbite. That mandible is going to be shifted to one side. Mm-hmm. Now you go orthodontically and just try to kind of like move the teeth. Well, that you're now unleashing a wild mandible that has been trapped mm-hmm. in a pathological position for a long time. So yes, you see on your ClinChecks or you see on your articulator that you're going to move the teeth and they will stay there. But no, the carpet underneath, which is the mandible, is now moving, and you never looked at the PGR role of this mandible and how it's changing. So then they end up with posterior open bite. Then they do more refinement, 20 more aligners, more refinement. Then I've done, when I was early on with Invisalign that we did not pay attention to any of this thing, there was cases that I had 100 aligners, with refinement.
Any orthodontist sitting out there who says they haven't had that is not being truthful. It's happened to all of us.
Yes. But once you're right, we all learned physiologic rest. What is the definition of physiologic rest? We all learned that. And I checked with dental students last week. They learned that in their denture course mm-hmm. because a completely edentulous patient is usually not a TMD patient. Why? Because no teeth. Right. The teeth are the guidance system for our orthopedics mm-hmm. alignment. So when you have no teeth, obviously the jaw will just relax its ideal position. Yep. So physiologic rest is the position of the mandible where muscles are happy and the joints are in the CR position. If we all start with that in mind, and then, move the teeth after maybe a phase 1 trial phase. We should not do jump into full mouth reconstruction or orthodontic, especially on patients that have signs of TMD. Symptoms are important, but there's a lot of signs of TMD or airway issue. And these patients, they're not linking it. For example, scalloping.
I can go through some of those if you don't mind.
Yeah. Scalloped tongues. What is the scalloping of the tongue telling you? It's basically that protrusive movement that the tongue is trying to stay away from the airway. Not necessarily popping or clicking of the joint. Sometimes in more advanced cases, they don't even make any noise, but they have limited range of motions, these patients. Mm-hmm. Numbness down their arms, neck issues, tinnitus, vertigo. These are not dental problems. Yes, they are dental problems because, it's all related. So if the clinicians, and I can share some assets with your audience, if you ask like 20 questions, some of these that I just mentioned is in those 20 questions, then the patients will start talking. They didn't know that numbness in their arm can be related to a mandible that's rotated, but we oftentimes correct that and it goes away. Tinnitus goes away. Vertigo goes away, and the airway is improved. So looking, again, I go back to a comprehensive exam. If you're just filling one tooth, that's fine. Or if you're doing root canal on one tooth, that's fine. But if you're changing orthodontically changing patients or doing full mouth reconstruction, you are dealing with airway and orthopedics of the head and neck. And you need to be aware of that to protect yourself and your patients. Liability is another issue that a lot of dentists deal with. A lot of, Invisalign did a lot of good things and a lot of bad things, because overnight it made all general dentists orthodontists. Why? Because they can just take an impression of just the teeth, send it to the aligner company, and some technicians are going to be moving your teeth to the ideal position. That works on an articulator, not on a patient that needs to breathe and use their muscles.
Yeah.
And so paying attention to their, again, I emphasize on that. I want everyone on Monday morning, when you go back in and you look at your patients, just pay attention to a few things. Check their TMJs, check their muscle spasm, check for, scalloping, linea alba, poor tongue function. If the patients cannot do this and suction their tongue to the roof of their mouth, they have poor tongue function.
That's a great tip. Yeah.
I always do that. I just ask my patients, try this. And most of them are like very weak. The tongue is weak. And I know some progressive orthodontists will send their patients to myofunctional therapy. That's big. Because again, that the built-in retainer, it's so important for long-term stability. Longevity should be on top of our minds, and that's why it just breaks my heart to see so many patients suffer for so long when there's a simple solution. It is a complex problem, but once you see it, you cannot unsee it, and it becomes such a simple solution.
Yeah, and I think a lot of it is people don't want to see it, and you kind of alluded to that. It's hard to see it. It's whether we're talking about airway, TMD, all of that. It's easier to just, especially in the orthodontic arena, but in fairness, in the restorative arena, it's easier just to start crowning the teeth, right? It's easier just to or in the peri arena, it's easier just to start doing the grafting, right? And do the procedure, or in the oral surgical arena, place the implants. It's easier to perform it because, as you said before, we're trained mechanistically. We are trained to do, and we bill for procedures, right? We bill for procedures. So as so often happens, sadly, the treatment follows the reimbursement. And we don't get paid a lot of money to diagnose. We don't get paid a lot of money to spend time with our patients in those consults. If you look at per hour revenue, what we get for doing our work versus our diagnostics, it isn't even close. We get paid exponentially more when we're doing the actual work versus the diagnostics. But what you alluded to, and I want to underscore is, I just want to take a minute and underscore it. When you do the diagnostics more thoroughly, your work gets easier. And it becomes more profitable and more lucrative because you cut a lot of the noise out, a lot of the headaches. It's not profitable to do 100 aligners on somebody. It's not. What maybe you did 4, 5 refinements in that window. I mean, you're paying the patient at that point to treat the case. And people might say, oh, Mike, Maryam, I only have a couple of those. It's still a couple too many. And I bet most people have more than a couple, of whether it's in restorative, that those crowns that keep breaking, right? Or that partial that keeps snapping, or the patient keeps fracturing their teeth and we don't know why. And we just keep extracting teeth. Taking a minute to look at these patients a little differently. So that's the next thing I just want to hear your thoughts on. When we see a patient, and I guess let's break it up into children and adults just to kind of help people kind of mentally compartmentalize it. We'll start with children. What are some of the main things that we miss? We talked about some things we see, right? But what are some of those ones that, they seem to be okay? Have you been able to figure out those cases that still surprise you or surprise others, or that we should be aware of that might not scream to us? We use the case for the retrognathic mandible with the severe anterior wear facets. Many people sadly do ignore that, but that's a pretty obvious sign that there's something going on with this patient. Are there other ones that are more subtle? Like, let's say somebody doesn't have really any occlusal breakdown, doesn't have, you're talking before about the linea alba or the tongue scalloping, or they have good tongue suction function, but maybe they just have like a little bit of a reciprocal click of one TMJ that they say just happens every now and again, but is not at all symptomatic. are those things, we'll start with kids and then adults, like are those warning signs? Are those things should we approach the case differently? And what would you recommend we do about it?
Definitely warning signs. We're lucky that most patients adapt to a certain degree of discomfort and pain. Mm-hmm. Otherwise, every patient would be in our chair complaining of it. But especially in kids. And I want to bring up the fact that a lot of these kids don't get proper care until they're 14 or 15. A lot of dentists, that see kids in their practice don't even refer patients out until they're 13 or 14. Their jaws have fully developed.
Yes.
But if you start at age 3 with
and we can still straighten the teeth, which is why a lot of orthodontists say, well, I can still straighten the teeth at that age. But what you just said, but their jaws have
already formed. It's
and
how much
airway, right? And all of the neurocognitive and behavioral issues that could last in that time. Thank you for bringing that up.
Yes, that all makes a big difference. So looking at kids is I, in my practice, because I'm a restorative dentist, unfortunately, I see the adults. So I see years of wear and tear and failure. And it really breaks my heart that if this patient was seen by their dentist 20 years ago, they wouldn't be suffering so much. Imagine how much healthcare saving costs we're going to
huge
by avoiding repeated treatment over and over again. So looking at the kids' airway and function, looking at breathing, I think breathing is the most important thing. And I think it was in 2020 that American Academy of Orthodontists released the white paper and
2019,
paying more attention to the airway. So it's great. We're going through that paradigm shift in dentistry that we're going beyond single tooth dentistry. We're not tooth mechanics anymore. We're the doctors of the head and neck, basically. We know our physicians don't like to look from above, so we're in charge. And actually, we're in a great position as dentists and orthodontists because we see our patients, especially general dentists, see their patients every 6 months or so. So you can, we're in the best position to educate our patients about their symptoms that is related to breathing and malocclusion, and we can really establish long-term stability for these patients by paying attention to these things. We're all here to give the best. We're not in dentistry to make money. We are. I mean, it's nice, but there's other ways to make money fast. We're here because we're all passionate about caring for patients and improving their quality of life. So paying attention, asking the right questions at the very beginning, planning things right, kind of like building a house. If you make the foundation right, it's going to last you forever. That's really what we need to pay attention to. And at the end of the day, they're going to save time because they're to see failures. I wanted to share a patient story, that came to me last year. She was 17 when she came to me. She could only open 20 millimeters. She was on a soft diet for 2 years, so skinny. She could not get good nutrition because she was just drinking most of her meals. And she said her jaw has been closed for 2 years like that. General dentist, orthodontist, she was in clear aligners, So when I did my TMD workup and I noticed that her mandibles was really retracted, and that's why she was in a closed position. So within a week, I was able to realign her jaw, open her to a 35 millimeter opening. And what she shared with me is that her provider, actually, her dental provider, talked to her and she said, this is part of her life. After suffering for about 3 or 4 years from age 13 to 17, which is almost a quarter of her life, the dentist told her that this is her and she just needs to learn to cope with pain for the rest of her life. So imagine a 17-year-old, she's going to be a mother someday that is dealing with chronic pain. And she might take her own life someday because she cannot be, she's not going to be fully there for her family, for her husband, for her kids if she's suffering. It takes a lot of energy to deal with chronic pain.
Yes.
And you don't have enough energy to spend it on better things. So this patient could have committed suicide someday. It really breaks my heart to see these patients, and then it breaks my heart to see that our providers are telling them that this is just their reality and they just need to cope with the pain. That is wrong. I changed her life. I did a orthotic, realigned her jaw, completely reversible, tested her. She was completely out of symptoms. And then we used the new physiologic position of the mandible, the correct alignment to finish orthodontics. Cases like that, there's a lot of cases like that. And as dentists, we need to realize that there's many people suffering, and that comes from our lack of knowledge. And it just takes a little bit of understanding. Just if you look at the anatomy, look at the development of the jaw, look at the airway, it just within 2 hours you can learn it and start implementing in your practice.
Yeah, completely. That's great. I thank you for sharing that story. And I think so often when we don't know the answer, we just kind of tell the patient, oh, that's what it is, right? It's just kind of like, I don't have any more for you, so I guess you got to live with it. You know, this is the way you're built. This is the way you're born. This is the lot you've been handed in life. And while there are, I'm sure, some situations where obviously things are true and there's genetic, there's syndromes and sequences and things patients do have as conditions, when we owe it to them to exhaust all the options and figure out why. And I think that's exactly what you're saying. Like, it's like we have to just look at this young, otherwise healthy girl who can barely open her mouth and barely chew, if at all, and just be like, it's the way it is for you. We need to do better. And you know what's so funny as you're saying that, Maryam, I'm thinking of in the orthodontic world, the 6-year-old who comes in and can't breathe and can't breathe through their nose. And they're mouth breathers, right? Snoring. And we're just like, yeah, snoring's normal. Snoring's fine. They'll outgrow it, right? It's not much different, really. It's kind of the same thing. We're like, I don't really know what to do about this. I don't really think anything I can do makes a difference. So, this is just the way they are, and let's hope they outgrow it. And where does that come from? I don't believe it comes from a place of malice or ill will or wanting harm or even not wanting to help. I believe it comes from a place of ignorance, that they just don't know what to do. Because as you said earlier in the conversation, we weren't taught this. And that's a whole nother conversation about needing to completely reform our dental education and medical education. I've had a bunch of episodes on recently with sleep physicians, and they talk about the same problem in medicine, the lack of understanding of some of these, of sleep, of diet and nutrition, right? I mean, these things that why is everybody turning to alternative sources to learn about these things? And sometimes they can get down a bad path. Why? Because our trusted medical institutions and dental institutions aren't doing their job educating young providers on this stuff. So yeah, they're going to end up finding some misinformation and stuff that's not true out there because they're looking for help. And if the medical and dental providers, instead of pointing the finger and saying, that's not a thing, that's not nothing I can do about that, point it back at ourselves and say, how can we be better? We can be such amazing healers as dentists. Yes. I mean, literally, like, I say that all the time, and I don't mean that to sound woo or like, no, literally, we can change lives. And I know it because I've done it. You know it because you've done it. There's nothing rewarding about creating a beautiful full mouth rehab and having, you were saying before, the extreme makeovers and that patient looking in the mirror and looking great, or in my world, giving a patient an amazing aesthetic smile, right? That's incredibly rewarding. If it didn't get at their etiology and it's a short-term fix, what have we really done for them? I mean, at the end of the day, right, it's going to break down. So on the breakdown note, and then I want to get into a little bit of your technique and how you're doing your diagnostics and some of what you've created with MyAligner. The big debate out there, right? And I get away from this debate, so I'll just kind of put that caveat out there. I'm not a big fan of the whole extractions cause airway problems versus they don't cause airway problems debate. My contention is the patient had the airway problem to begin with. The teeth didn't have room because they had an airway problem that altered the craniofacial growth and development, led to transverse discrepancies. People are always talking about, well, there's no literature to show that extractions cause airway problems. And I always say, because the airway problem was already there in the majority of these cases. It's not like someone walks into the oral surgeon or the dentist who's going to extract the teeth one morning and they're perfect nasal breathers and they have great sleep, and they walk out and that night they go to sleep and they have obstructive sleep apnea or sleep disordered breathing. Like, that's, you hear that and you're like, yeah, that's insane. Well, then it's because a lot of extraction cases in orthodontics, you're not even closing a ton of space. Like, there's some, but for the most part, you're extracting teeth because you've got, let's say each premolar is 7.5 millimeters, 15 millimeters of space in each arch. A lot of times you've got 10 millimeters of crowding. I mean, you're not closing an insane amount of space. That arch is already constricted. The maxilla is already narrow. The curve of Wilson's already steep. The tongue already doesn't have enough room, right? The palate's already high and vaulted. You're not causing it by extracting the teeth. So with that caveat laid out, I saw myself when I was doing restorative dentistry part-time, moonlighting during my residency, and I saw it in many adult patients who came to my practice who I hadn't treated when they were kids. And I've spoken to many restorative dentists and general dentists who have said in their practices, they have seen a significant number of their patients who are just occlusally destroyed as adults are missing premolars as well. Mm-hmm. Have you seen that in your patients as well? And what do you think about my theory that it's more of that the airway problem was there from the beginning and we just kind of treated around it, like the TMD, like we talked about before, versus the actual cause of it being the removal?
I totally agree, because if we go back 200 to 300 years ago, malocclusion did not exist.
Right.
A lot of archaeologists have shown us that, crowding did not.
Yeah.
So,
there was one study that came out, just to be accurate for people, that showed that yes, as some skulls aged, there was like 2 to 3 maybe I think it was like 1 to 2 millimeters of crowding developed over time in the lower arch, and people were like, "See, there was crowding." I'm like, "Yeah, we're 1 to 2 millimeters. We don't even blink at 1 to 2 millimeters. We don't even think about today." So I want to say it just because if someone's listening and they say, "Oh,
yes,
exactly, you're 100% right."
Impacted that just did not happen. So this is a modern problem that we're dealing with.
Yes,
because in modern societies, our modern lifestyles of not breastfeeding, not using food that dissolve in our mouth, not using our muscles for chewing. Mm-hmm. Obviously, everything atrophies and the occlusion. So that, again, goes back to my point of we need to diagnose these things early on, because before we have thousands of children suffering from ADD and ADHD, mm-hmm. because most of them are sleep issues. And this day and age, with having so many tools and devices and appliances in our hand, and also sleep studies. The sleep studies are so easy with just a few $100s, or with a ring that mm-hmm. costs nothing. You can do a sleep study and see if these patients are suffocating at night. Mm-hmm. Home sleep studies are very accurate now, and physicians are using that, and you can just have that with a few $100s for a patient. So we have the technology.
I'm hoping it comes out for kids soon, because I actually just had a sleep physician on my show, Saima Tahir, and another one, Avi Bar, who we were talking about that. And I'm like, when is this coming? Like, when are we going to get these diagnostics for kiddos? Because there's a lot of logistical challenges, but they both said it's coming. So. That's
great. But for now, we can just look at the signs and symptoms, refer them out to, for the kids. But for adults, we have it. We have the rings. We have all the, the watch pad techniques. It's really nice. So
do you use those in your practice as well? Do you help use it? You do.
I use watch pad, then I have a sleep physician make those and give us a diagnosis for
Awesome.
That. So, and then when you have a sleep diagnosis, it can go beyond just a MAD device or CPAP these days. So we have, we can do soft tissue remodeling with lasers these days. We can do expansion orthodontics, and also expansion restorative or physiologic restorative dentistry mm-hmm. that will establish function better. But my point is, try to avoid things that will harm the patient long term. Don't do anything irreversible that can harm the patient. Mm-hmm. And one of the techniques that I've been using in my practice is more of a phase 1 diagnostic therapy, and we do that with anatomical orthotics. So that can help us. It can be used as more of a diagnostic tool or treatment tool to give the patient some relief.
Yeah, talk more about that, if you would, your diagnostic process, including the ULF 10s, the ultra low frequency 10s, and the MyAligner, and kind of to solve a lot of these problems, what you've developed, because it is really fascinating, the approach that you've taken to this.
Thank you. Well, I think most of the TMJ damage and muscular issue comes from the mandible being distracted from closing on physiologic rest position. So that the dentists have been using deprogrammers, flat occlusal appliances to basically deprogram and bring that mandible back to an ideal position. So I think that's important. And that's what I use. I use a MyAligner, which is an anatomical orthotic. Patients can wear it day and night. I'm actually wearing it in my mouth right now. You can't see it. It's all the way back.
Wow.
So every time that I swallow, it's neurofeedback to my brain that my jaw is in the right position, airway is open, and then you can, after you calm the patient down, calm the symptoms down, test drive basically a new occlusion, then you can go to restorative if they have broken down teeth on the bottom, or you can go into orthodontics and move them to that physiologic position.
And about how long usually, on average? I know it can vary, but...
On average, patients wear MyAligner for about 3 months. So if your TMJ has been beaten up because of a pathological occlusion, that's how much time we need. Plus, the posture will adapt to it. Patients' function, breathing will adapt. So we give patients about 3 months.
A lot of adjustments needed during that 3-month period?
Not really, because we start from more of a neutral position of the jaw. We start from a neuromuscular CR, basically, joints are in the right position, muscles are happy. You start from that position, you build your appliance to that position.
Okay.
Most other treatment philosophies, you start with a flat device because you're trying to eliminate a pathological occlusion, and the mandible will take several months to kind of land to its ideal position. So those appliances need a lot of adjustment.
Okay, got it.
But one technique that has been FDA cleared, and I've been using it for 25 years, is ultra low frequency electrical neural stimulation. That stimulates through the coronoid notch. We're actually stimulating facial and trigeminal nerve. And the facial and trigeminal nerve, they have the motor nerves, and sympathetic and parasympathetic, because there's both nerves in those muscles. So what happens is that it calms down the muscles by tensing, and then it allows that mandible to land to its ideal position.
That was my question, is how are you determining that ahead of time? So it's really through the TENS, the ultra low frequency TENS, that you're able to achieve that.
I do that, yes, but some other dentists use kind of like a leaf gauge. They're looking at wear patterns that we talked earlier,
Yep.
And kind of like, okay, that must be their physiologic position. So they're using phonetic bites, they're using leaf gauge bites, whatever bite. You, as dentists, we need to give the right bite alignment or alignment of the mandible to maxilla to our technicians. They shouldn't be the ones that are changing the occlusion on the articulator.
Yep.
So we use a patient as an articulator with their posture and everything. We correct the jaw alignment. We test drive the jaw alignment with an anatomical orthotic that patients can use all the time. And MyAligner is segmented because of mandibular flexion. There's research, none of us as dentists will do a crown from 18 to 31 because of mandibular flexion. We know that that bridge will break. So we made it segmented to be used either on the posteriors if you have severe posterior drop-off, or if their video has really collapsed. We use 3 segments to basically test drive a new occlusion, give time to the joints to remodel, time for the function to improve, and then we'll go to phase 2. And some patients don't even go to phase 2. They if they're calm and if they can kind of like during the day function in their bite, and then at night we're the orthotic to be in the right position, that can happen too. So it's a reversible procedure that basically sets the foundation for you. It gives you a peace of mind that you're heading the right position. And then once you arrive that mandible to the right position, now you can easily do ortho, because then there's no compensation. You're doing expansion orthodontics and widening the maxilla, obviously the mandible will follow too. But once you capture the mandible in that right position and joints are stable in CR, then you're in a good position and your foundation is correct. And you can go with peace of mind. Believe me, it will save a ton of time for dentists. They'll actually be more productive than before. Back to production. If they just take that little bit of just maybe 15 minutes, looking for the signs and symptoms, asking the right questions, and then maybe do a trial phase for the patient before you go to the next phase would be great.
And what has been the patient feedback before we get to, I want to show an example of it here. What has been the patient feedback? How has it been received by patients? How easy is it taking it out? I did not know you were wearing one until you just said that. So it's certainly from a speech perspective. There you go. Yeah. From a speech perspective and an aesthetic perspective. Wow. Yeah.
Oh,
Yep.
okay.
Yep.
And so if I take this out and bite down,
So Miriam's showing how, she has a steep curve of spine in her lower. So she's over. There you go. Yeah, exactly. Yep. Her VD, she's lost her VDO over closing. Yep. And then, but she wants to be more protrusive and open for those who can't see. And then when she puts it in, go ahead and bite now for it. Yeah,
so
it
really helps with marionette lines, with retraction of the mandible. Mm-hmm. It's not going to push the teeth down or anything. We would just use it for 3 months to test drive that position. Mm-hmm. And then orthodontically, now we can upright these teeth to this new position.
Yep.
That's easy.
Yep.
And either with clear aligners or orthodontics. So, yeah, I was patient one back in 2019, but I was using similar concept, with the different devices. But since then, we've probably deployed about 2,000 of these between MyAligners, between my practice and our early adopters. And I constantly hear from practice, we haven't had one single complaint that somebody got worse. They're all getting better. Patients are getting better. So that's feedback. And we are collecting data from our providers. They're all looking at pre-treatment symptoms, post-treatment symptoms after 3 months. They're documenting it. We are sharing this through Bite Circle. It's a platform that we're basically sharing our knowledge. It's a HIPAA secure platform, and it keeps everything organized. If you want to look up bitecircle.com, it's a free platform for dentists, myofunctional therapists, ENTs, sleep physician, orthodontists, for all of us to collaborate and share our knowledge.
Oh, cool. I didn't know about that. Thanks for saying that.
Thank you. Yes, if they can look it up, bitecircle.com and join. Submit cases if you have a complicated case and you want to get some feedback from colleagues. It's just an easy platform that keeps the patient case and all their, let's say I say, send me the supplementary analysis for this patient, or what was their sleep study like. Then you can go under that patient and it keeps everything organized, right? And just email, forums that make things harder to find.
Oh, interesting. Cool. Yeah.
And again, it goes back to how challenging it is for multifaceted issues that are neurological and functional, which is TMD and airway and occlusion, to do randomized clinical trials. But the best way is for us to have thousands of cases before and after, even our failures. We should document our failures and learn from the failures. I think that would be the best evidence-based dentistry that we can have with these case studies. And I invite anyone to look at my case study. I published my case study. If you go to myaligner.com, and on the right-hand side, you see a research, click on that. And I have about 30 other scientific citations and research attached to that article. Basically, I showcase a case with facial asymmetry, mandible that was out of alignment, and unilateral crossbite that we were able to correct non-surgically.
Mm-hmm. Yeah. Before we finish up, can we do a little screen share here? So for those of you who are on audio, kind of at the hour mark here, we're going to be heading into just do a little 5 minutes here to show this one example so you can see what this looks like in practice. And I'll paint the picture here because Maryam has showed me the case ahead of time. It's an adult female with a unilateral posterior crossbite on the left side, which is something that walks into the orthodontic office not every day, but many days, and something that certainly in the general restorative dentist practice is probably in their office. It's every week, this type of occlusion, and asking, what could I do? And a lot of times we think it's surgical. Obviously this patient, just to paint the picture, if you're still listening on audio, the images are now up, it has a midline discrepancy with the mandibular asymmetry to the left. So clearly when she was a child, this was a narrow maxilla with a functional CRCO shift to the left, which we feel like the patient has just grown into that as orthodontists, and it's now their new permanent skeletal occlusion. And we assume that, but what Maryam's showing is that there can be some adaptation to that. So I'll let you take it from there.
Sure. Yeah, this is her CT scan. You can see that canine.
Can you go back to the pitch roll yaw for a second and show that on the jaw joint? I want to see, I love how you explain that. So go ahead. I think your approach to it.
Her jaw was, she came in with pain on the left side, left TMJ. She hated the asymmetry in her face and she had headaches. And I do a sleep study as part of my comprehensive exam, and I noticed that she had some airway issues too, even though she was not overweight. So the mandible, again, I've been comparing mandible to a plane. Mandible does not move like a car front to back. We say AP position or BDO. It's actually PYR. I'm hoping to change the definition of vertical dimensional occlusion to PYR because that's how the mandible moves. And then that's exactly what we see in this patient. So it's however you have the philosophy of taking a bite, you just want to make sure that you test drive it. In my case, I use some technology, I use tensing, and then that's what I use on this patient. After about 40 minutes of muscle relaxation, you can see this is her pathological bite. Look at the midline shift. So the patient naturally came to the ideal position. You can see there's a more intraocclusal space on the left side, which was her compressed side, compared to the right side.
So that's where she closed to. That wasn't a guided bite at that point, or that you didn't create that little PVS occlusal sort of guide for her. That's her. Okay.
Yeah, after her muscles that were posturing her mandible relaxed, her bite aligned like that.
And for those, again, if you're just listening in audio still, the patient now is biting with midlines on. So the shift is gone. Obviously, there's still a malocclusion there, but that would indicate that the compensation that I always thought and learned that is at that point skeletal, and she's essentially grown the mandible into that is asymmetrical position within 40 minutes of applying. She's able to, at that point, find a mandibular position with the midline on with the maxillary and facial.
So we use that, and then we build a MyAligner to that occlusion now.
Okay.
That's how it is in her mouth. So that's what stays in the mouth for about 3 months until patients get complete relief. Her TMD issues went away, and you can see the symmetry in her face just with a removable device.
Wow. And now at this point, it's pre-ortho. She literally, that's what you call your kind of phase one. It's the MyAligner, the deprogramming. And so, I mean, you could just see in her face, the balance and the symmetry is pretty dramatic. So
and the pain was gone. And at this point, she said, I want to do more. So we ended up doing orthodontics, basically with expansion of her upper jaw, that canine dropped into the occlusal cavity. You can see the whole picture in the documentation, in the publication that I have. And then, you can see she's wearing a retainer on her lower teeth and the uppers, because she started shedding some baby teeth. She had returned like 4 baby teeth. So we ended up doing some restorative on her too. So this is a bite circle. We talked about bite circle if you wanted to join and do that. Also restorative, another application is in restorative. There's a big applications in restorative. This patient, as you see, she had original bicuspid extraction. She was a severe sleep apnea case. One of my colleagues did some ortho expansion for her. You can see the space for the bicuspids are open now. So she had ortho done, she had expansion done, but her teeth over, she's in her 60s now, have worn down, uneven wear pattern. So she's still a restorative case. But again, before I go to finalize my restorations, I test drive it with a MyAligner.
Wow.
I put 3 segments on top, 3 segments on the bottom. You can see how her VDO changes, her PYR changes.
That's tremendous.
Yes, and that's the bicuspids that were extracted when she was a teenager.
Right. To our point before, as we were talking about, it was the fact that the etiology was a transverse deficiency, not big teeth, and so the extractions just didn't help anything and left her with the skeletal imbalance that she had. So when people hear, oh my gosh, reopening extraction spaces, that's crazy. Well, if you go back and treat the etiology and normalize the anatomy, you're going to get space in a lot of these cases. So you have to manage the space as well. And that takes some time and work, but that's really cool. The example you're showing now of her and how much it changes the VDO. And then, so at this point, you now know that's where you're going to restore her to, correct? At that point?
Yes.
Yeah.
Yes. And I think her AHI went from severe, like around 25 to 4 or 5. She dropped, her AHI dropped. So we technically cured her sleep apnea.
Yeah. Between the expansion and the change of the mandibular position.
Yes.
You essentially, I mean, it's life changing. So this is
tongue posture and all of that.
Yeah,
So
right.
it's a multidisciplinary approach. I cannot do this alone by myself. You cannot do this alone. We need other specialties to help us, and it's a collaboration between us, sleep physicians, ENTs, myofunctional therapists, physical therapists, chiropractors, everybody that deals with function of the head and neck.
Yeah, as I always say, it's a multifactorial etiology. The treatment has to be multifaceted and often multidisciplinary. So I really appreciate you coming on to talk about this and showing this and explaining this and getting into the science of it because, as people know with my show, I'm not about promoting a product or a company. I have no ties directly or indirectly to any companies or products. I want patient care to be accelerated. I want patients to get the care, the comprehensive care they deserve and they need. And that's why I love your approach because it goes into the diagnostics, it goes into the why, and it's getting at the etiology. And then once you have that settled, the restorative and the ortho, moving teeth is not that hard. Restoring, once you've gotten good at it, restorative dentistry is not that hard. What makes it hard? Imbalance, right? Muscular imbalance, poor occlusion. Those are all the things that drive us nuts, that make it hard to do what we do. So if we can take that out of play, pay more attention to the jaw joints, pay more attention to the airway, look at our patients comprehensively. Yes, it's harder up front. Yes, it's more time and energy up front, but I'm telling you, your cases are going to end up better. So before I have you share where we can find and connect with you, I'll leave you the last word to you.
Thank you. I just wanted to bring up one more point that all of us as dentists were taught to check for do cancer screening. 100% of dentists, when they do an oral exam, they do a cancer screening. Well, only 1% of patients end up with oral cancer, but 30% of patients suffer from TMD. 86% of patients suffer from malocclusion. So how many of us are really checking for TMD and malocclusion? Look at the big percentages. 30% of population means 100 million Americans alone in the US. So, with changing our approach where we can really impact public health, we can make treatment more accessible and affordable to more patients. Affordable because they don't have to do repeat treatment. I had some full mouth reconstruction patients that came back. They'd spent already $100,000 on their teeth, and everything was breaking. Once you get good at it, then you get your referral from other providers. It broke my heart to see how much these patients, they spend their life saving on their teeth, and everything was failing. This is a problem, and we really need, as dentists, we need to pay attention to that.
Yeah, well, I couldn't agree more. And thank you for bringing that to the forefront and what you're doing to develop products that can make our lives easier in the clinical world. How do people reach you, and how do people find more about MyAligner and reach out you?
Well, I'm always active on Bite Circle, so you can just hop on Bite Circle and collaborate with us, see some of the cases that we're treating. If you're interested in learning more about MyAligner, we have more of a treatment philosophy that's attached to it. So we have like a mini residency on TMD. We have a PACE-approved academy that teaches dentists. It's an accelerated program that can help you online, get some classes, then come to some workshops with us and start providing this. We've trained hundreds of dentists, making big impacts in their practice. So it's very fulfilling for me, and that's how you can reach me, through Bite Circle or MyAligner.
Well, thank you so much. I appreciate you and all you're doing. I've enjoyed, this is, as I say all the time, one of the most fun parts about what I do now is I get to interact with people like you. We met at the Airway Palooza meeting and we got talking, and Lauren Gates connected us, and we just got speaking about this. And I really enjoy what you're doing and how much you're a thinker on this topic, and keep us posted on how it goes, and wish you all the best and stay in touch.
Thank you. I'm really excited to be a part-time faculty at Airway Health Solution too. I'm going to bring physiologic full mouth reconstruction, basically a mini residency in full mouth reconstruction through Airway Health Solution platform. So I hope that you can join us, and if you're interested in more CE and learning this. But this is not about a device, but this is more like a philosophy of looking at the big picture. on Monday morning when you go back to your practice. Just make sure you look at some of the signs and symptoms. Well, I would be happy to share the sign and symptoms sheet.
Oh, perfect. That'd be great. Yep.
The exam with your audience.
I appreciate that.
So they can just share that with their hygienist and with their team members.
Love it. Dr. Maryam Motlagh, absolute pleasure. Thank you so much for coming on the Doc Podcast. I've really enjoyed it.
Thank you. Pleasure is all mine. Thank you. Bye-bye.
Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.